Basically, the presentation was supposed to give Dr. Mohammad Kalimuddin, but due to some emergency official work, he couldn't be here. So on behalf of him, I'm going to have his presentation. Basically, I am the continuation of my previous speaker. That's the reason of slow flow or no flow. Before starting the presentation, I would like to share an experience. During my first year of fellow training, while I was performing a coronary angiogram, left system level normal, and while I was maneuvering with the right catheter and cannulate in the right coronary, as soon as the catheter was engaged, all on a sudden, patient developed bradycardia, complete heart block. And my boss runs into the cath lab wearing the RCA and put a stent in the proximal RCA. So at that time, I realized that I did a mishap, that was a RCA dissection. So let's begin with the coronary artery dissection. What does the dissection means? According to the National Heart, Lung and Blood Institution, they define dissection as the intraluminal filling defect or flap, which may give an appearance of a haziness or groundless appearance. And the coronary artery dissection refers to the split or tear in the wall of artery, which compromises the lumen of the artery, resulting in reduction in blood flow. There are various classifications on coronary artery dissection. Mainly depending on the visual estimation, coronary artery dissection are categorized in 6 groups. Type A, that is a minor radiolucent area within the lumen, which is known as the luminar haziness. Type B, that is the linear dissection. There will be parallel lumen which will be separated by a radiolucent area. In these 2 groups, type A and type B, contrast usually didn't persist after dye clearance. Type C, that the extraluminal contrast staining. Type D, that the spiral dissection, and type E and F comprises a dissection which causes reduction of blood flow, and the last one, dissection, which causes complete occlusion of the blood flow. Usually type A and B remains the low risk part. Giving more emphasis on the left main dissection again classified into 3 types. Only localized to the left main, not extending to any branches, is categorized as type 1, whereas dissection extending up to the LAD or circumflex artery is type B, but the retrograde extension of the dissection retrogradely, that is extending out into the aortic root, is categorized as type 3. Again, the guide catheter induced dissection are also categorized in various, like the left main abrupt closure localized to the ostium anterograde or retrograde. Here, the retrograde Dunning classified in a different way. Like contrast, which only stain only to the coronary cups, that is one type of, and the contrast extends up to the aortic wall, but less than 40 centimeter. That is another. When it extends beyond 40 centimeter, this is another type of aortic dissection. Another classification by imaging, by IVUS or OCT, that is intimal, medial, adventitial, intramural, or intra-stent. By name, intimal means that the dissection will be limited only to the intimal layer. When it is extend up to the medial, so it termed as medial. And the intra-stent, basically after treatment of instant restenosis, separation of the new intimal hypoplasia from stent strut are termed as intra-stent. Here you can see the picture of OCT guided aortic coronary dissection. First one, the intimal, and B and C consist of intramural and medial dissection. It has been already said that the intimal dissection can be managed conservatively, but the two are really can lead to a very lethal condition, so they had to be intervened immediately. Here's a picture of OCT guided stentage dissection. And the IVUS, the arrow show the visible tear, and the circle here, it is the show the thrombus. Here is an angiographic show where you can appreciate the left main, there is haziness. So there is a dissection in the left main which was managed by putting a stent in the left main to LD. So in the era of the coronary artery dissection, there are some risk factors or some predictors that we should keep in mind while doing any intervention. This can be lesion related or technical related or maybe guide catheter related. So in the lesion related, long lesion, eccentric lesion, calcified lesion and complicated lesions are very much too prone to have dissection. Regarding technical factors, coaxial engagement is very, very important. So non-coaxial or deeply engaged catheter using of steep tip or hydrophilic tipped guidewires, oversizing or overinflation of the balloon, large bore catheters are included in the technical factors. Regarding guide catheter issues, left main M+ shaped catheter, myocardial infarction, vigorous contrast injection, deep intubation or various anatomy of the coronary ostia are also in the part of guide catheter induced dissection. The clinical feature from a patient can remain asymptomatic or may develop any kind of complication for a coronary artery dissection. Treatment strategy mainly depend on the type of coronary dissection. In the type A and B, it can be managed conservatively, but from C2 to type F, it should be intervened either by the PCI or by the cabbage. And in case of retrograde aortic dissection, the dissection which are less than 40 centimeter extended, they can be a watchful expectancy with surgical consultation, but more than 40 centimeter surgery is mandatory. Here you can see that there is a distal dissection of RCA which is again managed by another stent deployment. So what can be done to avoid this nightmare type of it? Meticulous handling of the coronary catheter is must with coaxial engagement. Monitoring of the pressure to prevent ventricularization or damping, proper catheter selection, and avoiding oversizing of balloon or inflation. So in conclusion, we can conclude it in a way that contemporary PCI is associated with a relatively low risk. Type A and type B can be managed conservatively, whereas other types need intervention. Prevention, of course, always is the first priority because it is better to stay away of travel rather than to get out of it. And continued education in the evolving field of PCI will allow further improvement in patient outcome to reduce the mortality related PCI, in also to reduce the cost of it, because if you need another stent for a complication in a country like ours, it really matters to put another stent. So from our team of Cath Lab, thank you very much.